on to the next speaker. Heart Failure Guidelines 2024, 4 Pillars of Treatment, a Bird's Eye Review by Dr. U.M.Nagamallesh.
Good morning, everyone. First of all, I would like to thank Professor Desai and Dr. Prabhakar for this opportunity. So I'll be speaking about Heart Failure Guidelines 2024. Is basically mainly a clinical pathway for the treatment of heart failure. So we all know the heart failure prevalence in India is increasing. It's almost, as per present data, 1% of the adult population is suffering from heart failure. That is translated into 10 to 12 million people. But I feel it is much more than that. If you see a 30 crore population of US, they have 15 million people suffering. So probably our data is not so much captured. So even though the globally heart failure is about 64 million, I feel India only having so many people suffering from heart failure. So Indian patients are younger, sicker, and face higher morbidity and mortality, including sudden cardiac death. Even though the chart looks very less compared to other part of the world, as I told you, probably our data capture is not so good. So heart failure is a chronic disease, which a chronic decline in the function over period. If you look at this, there is an acute episode in between this chronic progression of the disease. So each episode of chronic heart failure has 20% mortality. So if you see annually, third admission, you almost have a 60% mortality if you don't take care of these patients. So India witnessed a huge heart failure hospitalization, almost 30.2% 1-year hospital readmission rate. That is very, very high. That is translated into mortality. So this is similar across the gender, either it is a man and woman. Similar irrespective of the ejection fraction, this is very bad. So whether EF is 30%, 20% or 40%, the readmission rates are high. And 24% of the patients are at least readmitted once, and 5.8% is readmitted more than once. So this small population of 5.8% have very high mortality. So increasing mortality in heart failure patient across heart failure spectrum in India, mortality rate per 100% year of follow-up, heart failure reduced ejection fraction is 43.8% and preserved EF is 35.7%. So 1/3 of patients die within 1 year during their productive life years. So this is what it is much worse than any stage 3 CA. The current available therapies for heart failure is Fantastic Four. So in 2013, there were 3 main pillars of heart failure therapy. So all this has been discussed so far. That is AC inhibitor ARBs, beta blockers and MRA. That was the main treatment available in 2013. ARNI changed the face of heart failure treatment. In 2014, the sacubitril/valsartan, a new class of drug comprising angiotensin receptor nephroresin inhibitor, was tested against enalapril with the patient who are reduced EF. So in Paradigm Heart Failure trial, the largest clinical trial of heart failure with reduced ejection fraction, there is a 20% reduction in primary composite endpoint, CV death and heart failure hospitalization. So this ARNI keeps these patients out of hospital, asks them to live longer, as the hospitalization linked to the mortality. So this leads to change in guidelines after a decade. Now in 2024, there are 4 main pillars of heart failure therapy. That is ARNI, beta blocker, MRA and SGLT2. So SGLT2 has been discussed in detail just now. So heart failure with reduced EF, therapy should be initiated with the goal of reaching target and maximally tolerated dose of 4 key medication classes as soon as possible. Ideally, it should be no longer than 3 months. So this recommendation, because of the strong HF trial, showed safety and efficacy of goal of 50% target dose by hospital discharge and 100% target dose by 2 weeks following the discharge from hospital. So we are rapidly trying to achieve the maximum tolerated dose to reduce mortality and heart failure readmission. So in 2022, the guideline recommends sacubitril valsartan as class 1 and 11A evidence. Some patients will meet all criteria for initiation of ARNI but have not yet been treated with AC inhibitor or ARBs. So initiating ARNI among those who are not exposed to AC inhibitor ARBs also safe and effective strategy. So new guidelines focus on adding drugs rapidly. In conventional sequencing in a step 1, so we used to start AC inhibitor or ARBs as a first drug of therapy. And a step 2 is to add beta blockers. Step 3, mineralocorticoid receptor antagonist, angiotensin receptor or neprilysin. Then the step 4 is to withdraw the AC inhibitor and start ARNI and the SGLT2. So now in 2024 guidelines, the rapid sequencing has been implemented. That is, the step 1 is beta blocker with SGLT2 inhibitor, and step 2 is angiotensin receptor neprilysin inhibitor, and step 3 is the mineralocorticoid receptor antagonist. So while there has been considerable success in past 2 decades in developing heart failure therapies, there remain significant unmet needs for improved implementation to address the substantial residual risk. So basically, because of so many drugs and also their limitation of starting these drugs in many of the heart failure patients, so we are not able to achieve what is required to reduce the mortality and morbidity. So coming to ARNI, those who are previously on AC inhibitor or ARB, so you have to stop 36 hours before initiating. If patient is taking less than 10 mg of enalapril, we can start 50 mg half tablet of ARNI, and if patient is taking more than 10 mg, you can state 1 BD of 50 mg 1 BD. So you access in 2 weeks time, and you check the potassium. If everything is fine, you can step up the ARNI dose. So in those who are not administered ARNI, and you can consider for AC inhibitor ARBs, and if patient is stable on AC ARBs, you can always, after stopping 36 hours, you can switch over to ARNI. So MRA is initial dose of mineralocorticoid can be started along with the beta blockers. So consider increasing the dose of MRA in 2 weeks until maximum tolerated dose is achieved, and measure electrolyte 1 to 2 weeks, and then check monthly for 3 months and every 3 months for a year. If it's stable, then you can check less often. So SGLT2 inhibitor is the other drug which can be started as a second stage along with other drugs. So you should always check the GFR, which should be more than 25 to start SGLT2, or also check for other contraindication for SGLT2. So beta blocker, so always is a class 1 drug for the heart failure. So you can start with a small dose and increasing in 1 to 2 weeks time till the maximum tolerated dose. So if patient is come with acute episodes with a beta blocker, don't stop the beta blocker. You can reduce the beta blocker to 50% and stabilize the patient, and later you can increase to the original dose. So diuretic agent is required for patients who are volume overloaded and they have symptoms of breathlessness, and always monitor renal function when you are and also weight when you are starting diuretic, especially in SGLT2 and ARNI is added. So those who are African Americans or those who are not able to start ARNI or ARBs due to elevated creatinine, so hydralazine and isocyanated dinitrate can be started. So another drug, ivabradine, so it can be reassessed after beta blocker. If a beta blocker is started and still the heart rate is not under control, if patient is more than 75, start 2.5 mg twice a day, and if patient is less than 75, you can start 5 mg twice a day. Reassess the heart rate in 2 to 4 weeks. If heart rate is less than 50, if patient is taking less than 2.5 mg, stop the drug. If he is taking 5 mg, you reduce to 50%. If heart rate between 50 to 60, and maintain the current. So don't stop the drug if heart rate is 50 or 55. That is what your target is. If heart rate is more than 60, you can add this drug or increase the dosage. So for a stage C heart failure, ARNI, beta blocker, melanocorticoid blocker, and SGLT2 is what recommended. So this has been discussed already. So Verisogot is the other fifth pillar that Dr. Karthik Vasudevan is going to speak on this. I'm going to skip this talk. Another most important is intravenous iron therapy. So iron deficiency is emerging problem in chronic heart failure affecting half of the patient. Decreased iron status is associated with decreased disease severity and also hospital readmission. So iron deficiency is strongly and independently predicted with the outcome of heart failure. So inclusion of iron deficiency provide additional prognostic value when added prediction model with the established risk factors. So it is considered a class 1 indication to treat this patient with iron therapy. Conclusion, quadruple medical therapy and titrated to maximally tolerated target dose is a fundamental therapy for heart failure. Those starting small dose of all four and living there without targeting, reaching the target, you may not get the benefit. So rapid sequencing is what it is recommended to reduce the mortality. Otherwise, traditionally done, it takes 6 to 8 months to titrate the dose to the maximum tolerated dose. So intravenous iron therapy should always be considered in patient with heart failure. Thank you.
Thank you very much, sir.